Khaled, how do you want to handle the questions and answers? Are you able to see them, and do you want to just take them? Do you want to, is your voice such that you prefer Victoria and I to answer the questions?
Well, I think we can both contribute, but I think I'm starting to lose my voice. I'm starting to lose my voice, and I think I prefer that you guys take the first question is very simple. So I will give you the questions because what happened here, I'll tell you what happened. What happened is people are used to send me the questions, so they're sending me the questions, so I prefer to read it to you guys and you take it. So the first question is, I actually mentioned the transitional phase and portovenous phase. So what's the difference between the transitional phase and portovenous phase?
Wait a second, Dr. Elsayes, you want us to take questions?
Yeah, I ask you to take the questions because I'm starting to lose my voice. But I'm happy to take it if you want me to.
No, that's fine.
No, Professor Cherniak will be delighted to answer this question.
So what's the difference between transitional phase and portovenous phase, Victoria?
Okay, so so transitional phase is acquired when we use hepatobiliary agents with MR. Usually it's Geraxatate, which is known as Evist or Primavist. It's a little bit, seems like a pedantic and semantic point to name the phase differently from similar phase at the same time with extracellular contrast agents, but there's a good reason for it. Transitional phase is acquired about 3 to 5 minutes after administration of Geraxatate. And the reason why LI-RADS distinguishes between transitional phase and delayed phase with extracellular contrast agents is because on transitional phase, there's usually or often some contrast uptake by the parenchyma, which affects how the lesions will appear in the liver. And that difference may be only apparent when you use hepatobiliary phase images. So that's why transitional phase is a separate entity. It's not the same as delayed phase, even though they're acquired at the same time period after contrast administration. So again, transitional phase is acquired with hepatobiliary agents about 3 to 5 minutes after administration. Delayed phase, the same time period, about 3 to 5 minutes after administration of extracellular contrast agents. And then portal venous phase is the same for extracellular and hepatobiliary agents acquired somewhere between 70 and 90 seconds after contrast administration.
Thank you. The great speaker of today, Dr. Cherniak. So another question. Sorry, it's just thanks for the lecture. In observations that had been treated with local regional therapies, do you still use portal or delayed phase for an accurate measurement? Great question.
Professor Sterling, take that one.
Yeah.
Sure. That's a very interesting question. We'll learn more about the LI-RADS treatment response assessment in coming days. I believe Professor Richard Dew will speak on this topic in a couple of days. But briefly, in the LI-RADS treatment response assessment algorithm, what we're looking for in a treated lesion is the size of the area of arterial phase enhancement. That's the most important thing we're looking for. It's not the only thing, but that's the main thing we're looking for. So this would be an exception to that, where we might actually need to measure the area of enhancement in the arterial phase rather than on the delayed phase or portal venous phase. Especially if the area of enhancement is not washing out. If the area of enhancement is washing out, then you could measure it and probably should measure it on the portal venous or delayed phase. This is an interesting question that you're asking, though, and I would say that this is an area that may evolve over the next couple years as we learn more and as research is done. But for today, for now, until more research is done, I would say that for the treatment response assessment, see if you can see an area of arterial phase enhancement within a lesion, measure it, and you'll learn more about how to measure in a couple days, and then decide whether that area of enhancement definitely or only possibly represents an area of viable tumor. Again, you'll learn more about this in a couple of days.
Great. Thank you, Dr. Solomon. Dr. Zaytoun is asking, I think, interventional question. I don't know whether you guys will answer it. I have a question. I have a case 10 millimeter enhancing washout, not seen by ultrasound. Can I do selective TACE? That's what he's saying. 10 millimeter enhancing. You know, I think I will. I'm breaking good news for particularly for you, Dr. Zaytoun, because I think you've been asking some interventional questions. You know, after this series, I actually already talked to a great colleague who does liver interventions. He's a great guy. His name is Armin Marvash from MD Anderson, and he's going to give 2 talks back to back. One talk about the use of the general talk about liver interventional procedures, like all procedures, radiofrequency ablation, TACE, everything, and indications and the specific questions about interventional. And the second question will be particularly about Y90, because that's his particular area of interest. And so this is, I think I would defer this to this lecture, if you don't mind, Dr. Zaytoun. This will be May 18th. So mark your calendar. It's not still announced, so you're the first one to know that.
Khaled, can I answer that? This is Michelle.
Okay, go ahead. Go ahead and answer it.
So here in what we do is we usually present these at our, tumor board to see what the group decides as a whole and what is the best option in terms of, is it TACE or ablation or even Y90, SBRT. So I would say it really depends on the location. And, if you can do selective TACE, and, I think you can do it, but we usually do it as a multidisciplinary discussion with, the vascular interventionalist, the hepatologist, the surgeons, everyone there. I don't know if that answers the question, but.
Yeah, and I don't know also, because that's why I deferred it to interventional radiologist, Victoria, because with that size, and if it's like solitary, and if it's if there is good access, you will usually do ablation to it, not TACE. But anyway,
that was Michelle. Dr. says that was Michelle. But
yeah, but Khaled or Victoria, could you explain to could you introduce Michelle to the audience?
Michelle want to talk?
No, I don't mean that. I mean, well, Victoria, can you just explain to the audience who Michelle is?
Yeah. Michelle, please forgive me. I never can pronounce your full last name correctly, but Michelle Lala.
Just say Lala.
Michelle Lala is a fantastic radiologist who's both diagnostic and interventional radiologist, and she is our chair of the treatment response working group among many other fantastic projects that she's leading right now.
So Victoria, I think this question is particularly for you, having been significantly contributed to writing. Is the point about having portal venous washout without arterial phase hyperenhancement clearly mentioned in LI-RADS document? That's Ruba, our friend Ruba Ram.
Yes. So, well, if you just look at the table itself, you will see that there's not a single cell in the diagnostic table that assigns LI-RADS 5 category if there is no arterial phase hyperenhancement. So that's one point. But if you go into the manual in chapter 16, which goes into great detail of all imaging features and their potential pitfalls and nuances that ordinarily may not be apparent, we do explain that presence of arterial phase hyperenhancement is not necessary for washout appearance. However, the observation does need to be enhancing at least somewhat. So Observation can enhance to the level of the same as the background parenchyma, which would not make it arterial phase hyperenhancement, but it would be iso-enhancing. But then de-enhancement of portal venous phase will qualify this as a washout. Did I answer correctly, or did I misinterpret the question?
Yeah. You answered correctly, but you didn't mention the page number. You said the chapter number, but page number and sentence number and word number was not all. Was not all. No, it's amazing that you remember the chapter number and everything, the location and everything, Victoria. Appreciate that. So,
No, but can I, Khaled, this is Claude. Can I just add something? I would, Victoria and I and other members of the LI-RADS steering committee, including Khaled and Michal, who you just heard from, would be very interested if everyone who's listening in would actually download the LI-RADS manual and look at it and then give us feedback. Please feel free to look at it and tell us what things in the LI-RADS manual were confusing or what things didn't make sense, what things you wish we explained better, et cetera, et cetera, et cetera. This feedback will be very useful to us in making it better and making it more useful for you. So please, we encourage you to download the LI-RADS materials, including the LI-RADS manual, and please do give us feedback on how to make it better.
Great. Another question I want to hear, Thana Rabia. Can you please speak? Can you please give the question?
Assalamu alaikum. Just in case of corona enhancement, how can we measure the observation? Because now we have the central washout and peripheral enhancement.
That's a great question. Claude, Dr. Serlin?
Yeah, can you repeat the question? I didn't understand the question completely.
In case of corona enhancement, how can you measure the observation?
Okay. So I believe Professor Elsayes showed an example of that. I don't remember what slide number it was, Khaled. It might have been slide number 18, but you showed a case where there was, it was a CT, and in the right lobe of the liver, no, it wasn't this one, but in the right lobe of the liver, it was a CT. There was an observation that measured 15 millimeters in the arterial phase, but measured, I think, less than 15 millimeters on the delayed phase.
Oh, okay.
And there was corona enhancement.
Yeah.
By the way, I'm totally joking when I say it was slide 18. I have no idea what slide number it was.
You were trying to be like Dr. Cherniak. Sorry, I'm
trying to be as good as Victoria, but I can't be, so I should just stop trying.
Yeah, I'll show it to you.
No, keep going.
Yeah, I know what you mean. This one.
Yes, this one here. Yes. So here's an example where there is summation of enhancement between the corona and the actual nodule. And because of that summation, the nodule or the observation appears to measure 15 millimeters in size in the arterial phase, but that's not the actual size. That is overestimating the size. The size in this case can be better evaluated on the portal venous or delayed phase when the corona has faded from view. And you can see here that the lesion measures only 8 millimeters, not 15. So to answer your question, if you see corona enhancement, or if you see any sort of peri-observation enhancement, do not include the corona, do not include the peri-observation enhancement in your measurement. Instead, measure the observation on another phase or another sequence if possible. If you see the observation only in the arterial phase, if it cannot be seen on any other image, well, then obviously you have no choice. You have to measure it in the arterial phase. But if you see it on another image, it's better to avoid measuring in the arterial phase. This is a great case, by the way, Khaled.
Yes. Thanks. But if you revise the MRI case, if we did an ultrasound,
I'll show you the case. I think I know what case you're talking about.
Yes, the MRI.
Yes. Which is this case, but I think we can still. So I think
if we did an ultrasound for this case, what is the actual size of the observation will be?
Oh, very interesting. Okay, so wow, you're asking an amazing question. Okay, so what's the real size of this lesion? Ultrasound would not be detecting the corona, so most likely the ultrasound size of this lesion would be the size of this lesion on one of the images that does not show the corona. But I don't, that's my speculation. I don't think that there's any scientific data that proves beyond any doubt exactly what the correlation is of lesion boundaries on MRI versus CT versus ultrasound. But my speculation is that the ultrasound size would not include the corona. Yeah, this is an interesting. We will need to discuss this case, I think, internally within our steering committee.
Sure.
This is I would actually probably measure this case on the pre-contrast because I think on the delayed phase D, I think some of the edges of the lesion are now iso-enhancing to the rest of the liver, and so I think that delayed phase may be underestimating the true size of this lesion. That's just my opinion. I'd be curious to see what, Khaled, what you think, and Michelle,
No,
what
I
you
agree
think.
with you. I agree with you. I agree with you. The pre-contrast, it's about being most conspicuous and most well-defined, and I think the pre-contrast here is most conspicuous and most well-defined, right?
Yeah,
So,
often in cases where there's a lot of, whether it's the perfusion that you see surrounding, where on arterial phase it looks bigger, or on the portal venous delayed where you can't really tell, I often, not often, but I will sometimes measure it on the non-contrast, because sometimes I think you can see it, the margins really well on the non-contrast.
is it Michelle?
Yeah, that's Michelle.
Hey, Michelle, we are honored you're here, and we're looking forward to your lecture. That's great. Thank you. Thanks for the participation.
Please, in such case, we can use the pre-contrast for knowing the actual size of the lesion.
Absolutely.
Not the delayed. If it is very clear and very defined like this case, we can switch to the non-contrast.
Yes.
And use it as the actual size and in defining the LI-RADS.
Absolutely. Yeah, I think so.
Thanks.
So thank you for the very nice whatever. I have more general question. Do you prefer extracellular or hepatobiliary contrast agents when using LI-RADS, or do they both perform equally? What are the pros and cons in your experience? So Victoria, you're laughing, so you answer this question.
I'm laughing because it's a fantastic question that requires the entire lecture to address.
I know you have the entire lecture of EOS, so this will be a very nice.
Right. There are a lot of advantages to using gadaxetate in patients with cirrhosis. There are also some disadvantages that can be overcome, but not in all cases. So LI-RADS does not, at this point, recommend, doesn't favor any modality over another, and kind of accepts that this decision is made based on each institutional preferences, including what radiologists are comfortable reading, what surgeons want, what clinicians want, what best for any particular patient. For some patients, EVIS is not going to be the best contrast. For some patients, CT is going to be the best. MR is not going to be great for everything. But it's a very complex question that cannot be answered one way or another. There are a lot of factors that go into decision. But from my personal standpoint, and that's just my personal opinion, we use gadaxetate for cirrhosis in all patients who can get it. But that's not often the practice in other places.
So the second question that will come to you is like, what would you do with these artifacts that are frequently encountered in the arterial phase with EOVEST?
So there are ways to counter those, including advanced techniques, like acquiring multiple arterial phases. There's some data from Sinai that shows that when you do that, you're bound to have at least one diagnostic arterial phase. What we do at Montefiore is we actually dilute the bolus with normal saline. So instead of injecting 10 cc's of garaxetate, we dilute it with 10 cc's of normal saline. So you get a 20 cc injection, and it mitigates a lot of motion artifacts. So patients are still getting somewhat short of breath, but the effect that it has on image quality is lessened because you're expanding the bolus over time. It works very nicely, actually. At least in our experience, it works very nicely.
Great. Kirti, can you you want to give your question, Kirti? Kirti? Okay. So I would give the question. How will we characterize an observation that is hypoenhancing on both arterial phase, portovenous phase, and delayed phase? Do we consider it as washout without arterial phase hyperenhancement? Do we place it in LR3, LR1, LR2 regenerative nodules? So they are asking about hypoenhancing in both arterial phase, portovenous phase, and delayed phase. And I think it's just the washout that, again, going to the beautiful definitions of LI-RADS, has to decrease in enhancement or decrease in from the earlier phase to be considered as a washout. It was clear in the case which I showed that it showed isodensity in the arterial phase and hypodensity in the portovenous phase, and it was clear that this was decrease in enhancement from the earlier phase. But the scenario you're talking about could be several things, but based on what you're describing, that does not qualify for washout. If it's hypodense and maintaining hypodensity without decrease in enhancement from the earlier phase. I actually have seen cases of hypovascular HCC, and you can still look at the decreased enhancement in the later phases with these cases, and the development of enhancing capsule as well, or appearance of enhancing capsules. So I think this is based on the scenario that you're encountering. There is no one single answer for this, but you need to actually work it together with other features. So another question from Gafur. Thank you for this very helpful talk. Oh,
Thank you.
You want to go ahead? Go ahead. You want to talk? You want to give it?
No. I'm sorry, I missed that. Actually, I see a lot of cases, and then I'm confused whether to call it whether there's a washout or not. Because according to the carcinogenesis pathway, like sometimes we expect that the tumor has not yet developed its arterial hypervascularity. So,
I think,
like you mentioned. Hello? Yeah.
Yes. I think, look again at the definition. The definition is unequivocal. So I would not call it unless there is unequivocal, which is sure. Or what do you think, Claude?
Okay.
No, so Khaled, let me just say a couple things here. This is a very complicated topic, and so it's not simple at all. In the current definition of LI-RADS, according to LI-RADS, washout requires that there is some degree of de-enhancement of the observation relative to the liver. So if the observation appears to be getting darker over time, even without making actual measurements, if it looks like it's getting darker, we call it washout. Even if there is no arterial phase hyperenhancement. So even if the lesion is not hyperenhancing in the arterial phase, as long as there is some enhancement, so if there's no enhancement, if the lesion has no enhancement, it's either a cyst, an abscess, or it's necrotic, then we don't talk about washout. But if there's some enhancement, meaning that the lesion is alive, there is blood flow into that lesion, if it looks like it's getting darker, you call it washout.
Okay.
If it doesn't look like it's getting darker, you don't call it washout. In this particular case, if you think it's getting darker and you go to the LI-RADS table, that means there is one feature of HCC. And if the lesion has one feature of HCC and it's bigger than 2 centimeters, you call it a LI-RADS 4. If the lesion is less than 2 centimeters, you call it a LI-RADS 3. If it's an MRI, you can then go to ancillary features, and you can ask, does the lesion have any ancillary features of HCC, such as T2 or diffusion, height restriction, or fat, etc. And you could potentially use those features to bring it up from a LI-RADS 3 to a LI-RADS 4. Now, we know that there are going to be lesions that wash out, that have no hyperenhancement, and that are HCCs. So in the current version of LI-RADS, if it doesn't have hyperenhancement, we cannot call it a LI-RADS 5, even though it's possible it's an HCC. So this is an area of active research. I would encourage anyone who's on this phone call, on this webinar right now, if they're interested in research, this is a very interesting area. Can you develop criteria with which we can call lesions LI-RADS 5, even if they don't have arterial phase hypertension? So anyway, I may have given you more information than you needed to have. I hope this helped. If it doesn't, please let us know. Please also do look at the LI-RADS manual.
Yeah.
Let us know whether the manual is answering your question, and if it's not, let us know how we can improve the manual to give you the information you need.
So that's an informative answer. Thank you very much, Claude. And as stated yesterday in the ancillary features, I think ancillary features are one of the very beautiful things in LI-RADS, because with that specific scenario, you look at diffusion restriction, you look at the signal intensity on T2, which can be very helpful. You look at many other features that can help you make up your mind whether this is toward the malignancy or toward the benignity. And again, these features work together toward a specific category and toward making up your mind. So LI-RADS still ask you to use your mind and the thought process, proper thought process, to reach a specific category. And like what Claude said, also the multidisciplinary tumor board is also very important, because in some cases they feel with clinical context and other lab evidence of other things, and tumor markers would actually lead to biopsy. They make them decide on biopsy or follow-up or other management options. And these things all work together. So
Thank you very much.
Thank you. Tarun, would you want to actually give your question? Tarun? Let me give the question. Yes, go ahead.
Yeah, so hey, this is Tarun. I'm from UAMS. So continuing on that topic of arterial phase hyperenhancement, and it looks like it's a gray area, because you showed a case which is a pitfall where it's T1 hyperintense, and then it enhances, but actually if you look at the subtraction, there is no enhancement. So this phrase, some enhancement, is confusing, because either it's not enhancing or it is enhancing. The some enhancement part is really confusing. If you are using subtraction, then you know whether it's enhancing or not. So I guess in the future editions of LI-RADS, you may want to address this categorically, that either develop some criteria or say that both arterial phase enhancement and washout are actually independent criteria, and you just need to apply them independently.
So Claude?
No, we appreciate that feedback. I believe that right now in LI-RADS, we have that information in what's known as an FAQ, a frequently asked question. So in the LI-RADS core document and in the LI-RADS manual, we do explain that arterial phase hyperenhancement and washout do not need to spatially coincide and can be evaluated independently, but or should be evaluated independently, but it's possible that we don't make that clear enough. So this feedback is very helpful to us, and we will try to make it more clear in the future. So thank you.
Yeah, thank you so much.
Thank you very much. I think we have the last question, maybe last question. Yes. Abdullah, would you want to give your question? Okay, then I will give the question. Thanks, Dr. Khaled. How to evaluate washout in case of severe hepatic steatosis? Victoria, would you want to answer this?
Right. So this is also a fantastic question. Sometimes it's difficult, and sometimes you need to do some interesting things like doing subtraction images. Sometimes, actually, we've done a couple of times where we actually created curves, just like you would for prostate or for breast. We downloaded the images into the same software and just created rough curves to show that there's enhancement washout, but sometimes it's just not possible. Especially you will run into this issue when there's a lot of background cirrhosis. You may not be able to demonstrate, not demonstrate, but to call something a washout just because that's a pitfall in the definition. We have to have signal in the background liver. So sometimes it's difficult, and sometimes you won't be able to.
Okay, so thank you very much, everyone. We really appreciate your coming from all over the world to attend our series. So thank you very much, Dr. Cherniak and Dr. Serlin. We appreciate
Thank you very much.
No, Professor Elsayes, thank you for your great lecture, and thank you for being such a gracious host, and thank you for organizing this entire lecture series. So all thanks go to you.
Oh, thank you very much. That's very kind. Thank you very much, Victoria, too. Thank you, Claude, Dr. Serlin, Dr. Cherniak, and everyone. And we'll look forward to also having all of you tomorrow. And I'm going to send also the link to the lectures to everyone. And these lectures will be also uploaded online, and the link will be sent to all of you. We appreciate your coming here to attend our series, and we're going to extend it. And I'm going to announce this after organizing the new schedule for more lectures. You guys encouraged us to give more, and we appreciate your interest. Thank you very much, everyone. Appreciate it.
Thank you, guys.